Let's talk real quickly before we close this session about sort of the toxicity of checkpoints. So, Johanna, I'll pick on you first. So what do you tell a patient right before you're about to give them this kind of immunotherapy?
So I tell my patients, typically for folks that have received chemotherapy before, in general, when they get the immunotherapy, they feel like I'm giving them water. They were surprised there's anything in the bag. But what I worry about is revving up their immune system so much that it starts to attack the body itself. And so that can range from things like rashes, itchy rashes, to issues with their thyroid, to things that are even more important like pneumonitis, colitis, hepatitis, and even for the more rarer toxicities, and this is more for the clinician to keep an eye out for, is hypophysitis, where you could burn out somebody's pituitary gland. You can have myositis, you can have encephalitis. I mean, all of these things, very, very low chance, but they can happen. And the most important thing to let the patients know is even after they're off therapy, if they go to the emergency room with a problem, to let that treating physician know that at one point they were on immunotherapy, because you can see toxicities happen months out.
Front page of the Washington Post a week or so ago, a story on immunotherapy toxicity. Both patients that were featured were delighted to be alive, but they were talking about the side effects. I think about educating the public, which is what the Post is out to do, but I also think, we have hospitalists, we have ER doctors, and our patients are showing up in these venues and not necessarily being familiar with that. Are you all sort of doing some dedicated training of our colleagues?
We're actively trying to do this as we speak, because it is a big issue, and I think that's very, very important, because they will automatically tell the patient, somebody that's on call, oh, go to the emergency room, when in fact it may not be something that needs to be addressed emergently, but something we could address because we're familiar with the toxicities.
Yeah.
So.
And we're spending a lot of time with, say, pulmonary or derm saying, is this cancer progression? Is this immunotherapy toxicity? And sort of interventions, y'all have guidelines on how to treat this when it comes up and is bad?
I mean, that's one of the things. We're also working with hospitalists and the ER docs, and we don't have like a formal education process, but I think just through the spirit of collaboration, the ER docs are pretty quick to give us a call and say, we have a patient here, what do you think? And so I think they have good awareness and they ask good questions, and I think that's a good thing.
Is pseudo progression real? We talk about it a lot, and
depends on the drug.
Well, so with these kinds of drugs, is this real? Does this happen? Anybody seen it?
Yeah. I mean, it appears to be, at least in, say, the melanoma literature, with ipilimumab, it is more likely to happen than with, say, nivolumab. I think in the MSI patients, I think you mentioned you may have had one that had pseudoprogression, but I haven't really seen that to be the case.
So if they progress on their first scan, give it a little longer?
Yes, I would, but I mean, if it's true progression, I mean, they're symptomatically more.
We talked about expense, so we have to make this judgment. Is another 2 months of treatment worth it if they've progressed at the first one?
Yeah, I mean, I think pseudoprogression, hard to say, probably in the single-digit % range, and usually if you see it, it's more thought of that the lymph nodes are getting a little bit bigger. The other thing, though, is that you get patients that will be on immunotherapy for a long time, and then all of a sudden they seem to have progression, whether it be new lung lesions and such. And I've actually found people where it's not recurrence of their disease, it's not spread of their disease, we've gone in and biopsied it, it's just an inflammation but not a pneumonitis, or just something that goes away on its own. So just be careful with some of those folks that have been doing well for a while, then all of a sudden seem to progress. Or also in practice, the isolated lesion that grows on immunotherapy, don't throw out the baby with the bathwater. A lot of times we'll do single point radiation to that one lesion, then people go on for a long time on the immunotherapy after that. So
how long should I keep the drugs going?
Magic question. We don't know.
2 years.
2 years.
Well, 2 years is because all the trials were created for 2 years maximum.
That's
We
where
don't
our
know.
data is.
Yeah.
And I'll tell you too, there was data that David Spiegel presented from atezolizumab lung studies at last year's ESMO that looked at people who got, actually I think it was nivolumab, so checkmate studies. It was nivolumab for a year, and then stop and keep, or keep going. And the patients that kept going did better than the ones who stopped. So it's a tough decision.
Or do you just give them less frequent?
Maybe spread them out
Correct.
a little bit.
Yeah. And people are looking at that now too.